Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're talking all about blood transfusion reactions. As always, let's kick it off with our practice question. A nurse is caring for a client receiving a unit of packed red blood cells. 10 minutes into the transfusion, the client reports chills and feels itchy. The nurse notes flushing on the face and a temperature increase from 37.2 degrees Celsius to 38.4 degrees Celsius. What is the nurse's priority action? We have A, slow the infusion rate and reassess in 15 minutes. B, stop the transfusion and keep the IV line open with normal saline. C, administer PRN acetaminophen and continue the transfusion. Or D, notify the provider and wait for new orders before taking further action. Think about what you would do as the priority, and we will circle back to the correct answer at the end of the episode. But before we get way deep into all the different types of reactions and your priority actions, we really have to talk about what a transfusion is at the microscopic level. I want you to think of blood as a delivery service, all right? We've got a few different components here. First, the red blood cells, and they're the trucks. Now, plasma is the highway that they travel on. And the immune system is the security team that's protecting this delivery. When we transfuse, we're basically bringing in trucks from a different company and driving them onto our client's highway. That's helpful as long as our security team gives their badge of approval before we let them in. So what is that badge of approval? What is our immune system doing to let these other delivery trucks, these other red blood cells, come on into our blood and drive on our plasma highway? Well, on the surface of every cell, we have antigens. These are basically little name tags. They're made of proteins and sugars, and the big ones that I'm sure you already know are A, B, O, and our Rh factor. So if you're type A, your red cells wear an A name badge. If you're B, they wear a B, and type AB has on both name badges. Now, what if you're type O? That means that your cells do not have any name badge on them. So that's kind of our first category. And then our other one is the Rh factor. You can think of this kind of like a name badge too, but you basically either have it or you don't. You're Rh positive if you have this protein, you're Rh negative if you don't, okay? So I have A negative blood. My red blood cells have a name badge for A on them, and they do not have the Rh name badge. And in everyone's plasma, you're going to have antibodies against any of the antigens that you don't have. So since my cells wear an A name badge, they've never seen that B name badge before. That's going to be foreign. So it's going to have antibodies against that B antigen. For somebody else, if they have type B blood, they have the B name badge on their cells, they would be the exact opposite of me. They've never seen A before, so they're going to have antibodies against A. If you're O, you've never seen any of these name badges before, so you're going to have anti-A and anti-B antibodies. But if you're AB, you've got it all, so no antibodies, okay? That would be why O is the universal donor and AB is the universal recipient. So let's bring this back to a transfusion. We all know the immune system's basically entire job is to say what is me and what is not me, what is foreign and that I need to go attack. So when we transfuse blood, we do not want it to be attacked. We need those delivery trucks bringing oxygen and nutrients. So it needs to be compatible blood with the same name badges on there so we don't make antibodies against it. Let's say that me, somebody with type A blood, gets type B blood. Well, I have A name badges. I've never seen B before, so I'm going to make antibodies to B. You give me type B blood and my body is going to freak out. Those antibodies, they're going to bind to the donor cells like little handcuffs. They're going to be throwing them in jails. And that activates a cascade called the complement. It punches holes in those donor cells, causing acute hemolysis, the rapid destruction or breakdown of those red blood cells. The hemoglobin starts spilling into the plasma, which can really hammer the kidneys, jam them up, and clog up all their little filters. Basically, it can lead to shock. We can get kidney injury, we can get DIC. It is a full on immune warfare where our body is attacking the cells. At that cellular level, it is ripping them apart. Now, that's a full blown ABO mismatch. Something crazy happened here. We really, honestly, we don't see this happen a lot because if I go in with type A blood and you give me type B blood, somebody really messed up somewhere, okay? More commonly, we have smaller problems where it's not full on warfare, where we're pulling cells apart. Rather, our immune system is getting a little annoyed. For example, an afebrile non-hemolytic reaction is when the recipient's immune system reacts to donor white blood cells or cytokines that kind of came along for the ride in those products. This does lead to an inflammatory response because they're like, hey, you're not really supposed to be here. We're going to get aggravated. We're going to get a fever. We're going to get chills, but we don't have this full-blown mismatch of, hey, your cells are not mine, so we're going to tear you apart. We're not going to cause that hemolysis. The red cells are correct, so they're still intact. The immune system is just, releasing inflammatory products, helping us reset. They're jacking up the thermostat, giving us a fever because they're trying to kind of smoke the bad guys out. So they're a little annoyed, but again, they're not ripping the cells apart, so we're not getting that full-blown hemolysis. Another flavor we can see is an allergic reaction. So again, this isn't a full-blown ABO mismatch. We don't have antibodies going and tearing apart red cell antigens. What this means is that the recipient has IgE antibodies reacting to proteins in the donor plasma, all right? So it's going to look like an allergic reaction. Mast cells and basophils start to degranulate. We release histamine, and that causes vasodilation, increased capillary permeability in the skin and mucosa, causing those typical allergic reaction signs: hives, itching, flushing, maybe even in a severe case, angioedema or bronchospasm. Most of the times that I have seen this, it has been a mild reaction and mostly in the skin. So that itching, that redness, they're super uncomfortable. Again, looks like they're having an allergic reaction. It is, kind of a body-wide histamine storm. But again, it's the recipient's IgE antibodies reacting to proteins in the donor plasma. It is not a mismatch of those antibodies. We're not tearing those cells apart. Phew, okay, that was a lot. We just talked about several different types of reaction. A full-blown hemolytic reaction where we had a mismatch and our body went on and attacked and tore those cells apart. We had that immune system getting a little bit more irritated. We looked at a febrile non-hemolytic reaction where it was more so the immune system getting a little irritated. It saw some of those donor white blood cells and caused some inflammation, but not hemolysis. And then we saw an allergic reaction, that body-wide histamine storm. If you zoom out and think about the commonalities of any of these, anytime you hang blood, you are introducing foreign antigens, cytokines, plasma proteins, and volume into a complex system that is fiercely defensive. All of our bodies are built to really protect us from anything foreign. It does not want intruders getting in here. And when security sounds that alarm, it is a really big deal. So our key, what we're going to look at in our case study together, is figuring out when that alarm is going up so that we can intervene before the damage is spiraling. What I'm trying to say is that the first 15 minutes of a transfusion are a huge deal. That's when the alarm bells go off. That's when the body starts acting up, and we have to respond in real time to shut things down. So on into our case study. You are working the night shift on a very busy med-surg floor, of course, and you have a 62-year-old client admitted with symptomatic anemia from a GI bleed. His hemoglobin was 6.8. He's pale, fatigued, but he's stable, and he is getting 2 units of packed red blood cells. All right, so let's kind of go through what we do when we are hanging blood. This is super typical. The client has had a bleed, they need some blood. We're going to give them some blood. The first thing is you're going to verify consent. We have got to have a signed piece of paper saying they are A-OK with this blood transfusion. All right, that's checked off. Next, we are going to check the type and cross match. And you've got to do that dual check with another nurse, okay? We want to make sure if this client's getting, type A blood, he has type A blood. Remember that type O is the universal donor. It does not have any of those name tags, those antigens, and very frequently we give type O blood. So you want to check that this blood has been cross-matched. We are not giving incompatible blood to this person, because otherwise we're going to attack that blood. We're going to cause a hemolytic reaction. So you verified consent, you checked that type and cross match, and then you're going to pull out that blood bag in that order and double check it with another nurse. You've got the right client, the right unit of blood. You have checked that ABO and RH compatibility. You're looking at the expiration date. You also have to look at your client's vital signs, a baseline set of vital signs before you hook up that transfusion. And you're doing this with another registered nurse. So baseline set of vitals, let's go. We've got 37.1 Celsius, a heart rate of 88, BP of 124/76, respiratory are at 18, and 96% on room air. All right, does everything check out? Are we missing anything? We've scanned all our barcodes. We're good to go. Spike the unit and start the transfusion, but you do so slowly. This is crucial. Remember, if something's going to go wrong, it's most likely going to be in that first 15 minutes. So we start slow and we stay at the bedside. You can chat with them, you can tidy up, you can do some charting, there's lots of things you can get done in the room, but you want to be right there watching them like a hawk to see if their body is rejecting this transfusion, getting mad, getting inflamed, or, having a hemolytic reaction where it's starting to tear apart cells. All right. Now, here's where your case study is going to go. About 10 minutes in, you're cleaning up the room or whatever. He's kind of shifting in bed. He tells you he feels weird. All right. Quote, weird. Kind of cold, itchy. You look at him. His cheeks are a little flushed. His time for a vital recheck. Okay. You're kind of like, okay, let's take a look at these vitals. Now, typically we would get a baseline set and a set 15 minutes in. We're only 10 minutes in, but he told us he's feeling kind of funny. So we recheck his temperature, 38.1. To remind you, it was 37.1 when we started 10 minutes ago. Heart rate is now 102, up from 88. Blood pressure, still fine. He's not short of breath. His lungs sound clear. He doesn't have back or chest pain. We just see that the temperature is up and the heart rate is up. Okay. He feels weird, kind of cold and itchy. So in my book, this is a fever and chills. All right. Those are two very early signs of an acute hemolytic reaction. They're also classic for like a febrile non-hemolytic reaction. Okay. He said he's a little itchy. That could be allergic. The distinction, it does matter, but in the real world, if I see that the temp goes up and the heart rate goes up, I suspect a transfusion reaction. I honestly, guys, I don't even care what type it is at this point. I just know his body is not liking this. It is not normal for the temperature to increase in the first 15 minutes of a transfusion. So what are you going to do? What's your priority action? This is your takeaway for the whole episode, y'all. Stop the transfusion. If you have any inclination, if your nurse gut tells you, I think that this person is having a reaction, you stop the transfusion immediately. Now, leave the IV in place, disconnect that blood tubing, and hang a fresh line of normal saline to keep that vein open. Only after the blood was off do you then go call the provider. Okay, A lot of times in the NCLEX world, we think like, when do I call a provider versus when do I do an action? When in distress, we don't assess. And if there's something we can do to help the situation, we do that. And then we call the provider. And in this situation, if I were to just leave that blood running and, call up my provider, I am letting the reaction get worse while I'm talking on the phone. There's something I can do. I prioritize that. So I stop that reaction. Then I'm getting right on the phone. I'm notifying my provider. I'm doing a focused assessment. So what are we assessing for? What are those classic signs of hemolysis, of that acute reaction where cells are getting ripped apart? Back pain, chest tightness, shortness of breath, dyspnea, hypotension, crackles. We're not seeing any of those things in this client. His back feels fine. His breathing is fine. His SpO2 and his respiratory are normal, etc., etc. So a full-blown hemolytic reaction, less likely, not impossible. Next thing I want to look at in my focused assessment is his urine. I want to look for dark Coca-Cola colored urine because in that hemolytic reaction, we're tearing cells up, we're dumping heme, and we can clog up those kidneys. We can cause an AKI. His urine looked fine. What does he have going on? He's got that low-grade fever. He went from 37.1 up to 38.1. He's got that chills. His cheeks look flush. He feels itchy. He tells you he feels weird. So the provider orders IV diphenhydramine and acetaminophen. IV diphenhydramine, your Benadryl, that's going to help with the itching. Acetaminophen, that's your antipyretic. It's going to help with the fever. And then you send that blood bag, tubing it all, back to the blood bank, along with a fresh blood sample and urine specimen so that they can run checks for any hemolysis. So we've stopped this blood, and we see that over the next 30 minutes, things stabilize. All right, temp comes down with that acetaminophen. Itching resolves with that diphenhydramine. Nothing else progresses. The blood bank runs their checks. They get back to you in about an hour, let you know this looks like febrile non-hemolytic. It could be more allergic, but we don't see any hemolysis. They have looked under the microscope at that blood and urine sample. They do not see cells that got torn apart. So what do we do now? He had a GI bleed. We still need blood. Do we order some more blood? Do we do another type of crossmatch? What do we do? Well, we're going to try again. We are going to give another unit of blood. We are going to check that type and cross-match to make sure we are giving the correct blood. But we're also going to order some pre-medication before this next unit to hopefully set this client up for success. Pre-meds are usually acetaminophen and an antihistamine. In my experience, it's most always diphenhydramine. And we're going to infuse it even more slowly with very close monitoring. So again, you are glued to the bedside. You are watching those vitals. And if any of them change, remember, we're really looking close at heart rate and temp. You're going to be ready to stop that transfusion. Which brings me right back to our practice question. I think you guys are going to know the right answer now and hopefully understand why. You are caring for a client receiving a unit of packed red blood cells. 10 minutes into the transfusion, they report chills, they feel itchy, they are flushed, and their temp has increased from 37.2 to 38.4 degrees Celsius. What is the nurse's priority action? We have A, slow the infusion and reassess every 15 minutes. B, stop the infusion and keep the IV line open with normal saline. C, administer the PRN acetaminophen and continue the transfusion. Or D, notify the provider and wait for new orders before taking further action. All right, think, what do we do first? What's your priority? What keeps your client alive? I think you guys know it is B. When we suspect a reaction, we stop the transfusion and we keep that line open with normal saline. Reasons we would expect a reaction or suspect a reaction, I should say. They start to get a fever. It is not normal for that temp to go up during a transfusion. They get chills, flushing, itching, especially in those first 15 minutes of a reaction. Now, for hemolysis, we are going to be checking their kidneys, worried about dark Coca-Cola colored urine, shortness of breath, and back pain. Those are things that are really going to send alarm bells off. We are going to have to act super fast. A, just slowing the transfusion, not safe. C, just, give them some Tylenol and push on, not safe. And D, notifying the provider and waiting for orders. We do not have time for that. That does not keep our client safe. They are in distress. We are going to take action, and that action is to prioritize discontinuing the transfusion. Then, of course, you'll call your provider. And that's really your key takeaway from today's episode. A blood transfusion reaction is your immune system reacting to something foreign, an antigen, a protein, and it can range from, annoying, where we get a fever and itchiness, to life-threatening when we rip cells apart due to an ABO mismatch. All right. Your priority as the nurse is to recognize the early warning signs, get baseline vitals, watch them like a hawk for that first 15 minutes. If you see a fever, chills, itching, flushing, back pain, chest pain, dyspnea, you need to stop that transfusion and then notify your provider. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.